Hi everyone, my name is Laura Michelle Castro Chavez, and my topic is pregnancy adapt to yours algorithm for diagnosis of suspect pulmonary embolism. In the summary, pulmonary embolism is one of the leading causes of maternal death in the Western world. Due to the low specificity and sensitivity of the D-dimer test, our pregnant woman with suspect pulmonary embolism sometimes undergo computed tomography, pulmonary angiography, or ventilation perfusion examination. We have a video.
Few studies have evaluated the use of clinical decision rules, or D-dimer, to diagnose pulmonary embolism in pregnancy. The years criteria are used to evaluate suspected pulmonary embolism. They include three criteria to assess risk: clinical signs or symptoms of DVT, hemoptysis, and pulmonary embolism as the most likely diagnosis. On the basis of these criteria and their D-dimer result, patients may then undergo CT pulmonary angiography. In this multi-center international management study, 498 consecutive pregnant patients with suspected pulmonary embolism were assessed for D-dimer concentration and the years criteria. Patients who met none of the criteria and had a D-dimer concentration of less than 1,000 nanograms per milliliter, or with one or more criteria and a D-dimer concentration of less than 500 nanograms per milliliter, were considered not to have pulmonary embolism. Of the remaining patients, in those with clinical signs of DVT, the years criteria were adjusted for pregnancy to include compression ultrasound for DVT. In the absence of clinical signs of DVT or a negative ultrasound, CT pulmonary angiography was performed. The primary outcome was the incidence of venous thromboembolism in patients with initially normal tests during 3 months of follow-up. The key secondary outcome was the percentage of patients in whom CT pulmonary angiography was not indicated. With this approach, the primary outcome occurred in one patient who was diagnosed with popliteal DVT. No patient was diagnosed with pulmonary embolism. 39% of the patients were managed without CT angiography. Among the subgroup of women in the third trimester, 32% were managed without CT angiography. The authors conclude that the use of the pregnancy-adapted years algorithm safely ruled out acute pulmonary embolism in pregnant patients referred for suspected pulmonary embolus. Full study results are available at nejm.org.
Okay. Application. A year's algorithm charted for pregnancy could safely rule out acute pulmonary embolism (PE) in all trimesters of pregnancy, most effectively during the first trimester. Pulmonary computed tomographic angiograms (CTPA) could be avoided in several patients. Acute PE during pregnancy remains one of the leading causes of maternal mortality in Western countries. Given the low specificity and sensitivity of the D-dimer test, our pregnant women are advised to undergo an APTC and ventilation perfusion scan, which exposes both mother and fetus to radiation. The year's algorithm for diagnosing PE has worked well in the general population with suspected PE and has reduced the use of APTC. A year's algorithm adapted for pregnancy could therefore be a valuable tool for detecting suspect PE and achieving a diagnosis without radiation. We have another video.
Welcome to our channel. In this video, we will see what is the risk of pulmonary embolism during pregnancy. For more information, please click the links in the description. Pulmonary embolism is the leading cause of death in pregnant women, and yet it is not always easy to detect it. In this video, we will shed light on this subject and explain the contributing factors as well as the possible treatments. What is a pulmonary embolism? Although unknown, this pathology is more frequent than it seems. Pulmonary embolism occurs when a clot that has formed in the legs, phlebitis, goes back to the heart and blocks the pulmonary artery. Pregnant women are more likely to be affected by this disease, with 1 in 1,000 pregnancies affected by embolism. In 30% of cases, the outcome can be fatal. What are the causes of pulmonary embolism? Why is the pregnant woman more affected? The first explanation is that the uterus, when enlarged, compresses the veins and prevents the blood from circulating properly. The hormonal fluctuations undergone during pregnancy can be an aggravating factor. Hormones, in particular estrogens, damage the wall of the vein, which can also undergo a real trauma during the delivery. Except pregnancy, hormonal treatments can also favor the development of phlebitis, that it is those which one undergoes within the framework of stimulation of ovulation, or with the pills of third and fourth generations, which have been the subject of many controversies recently. Symptoms of pulmonary embolism. If pulmonary embolism is so complicated to detect during pregnancy, it is because its symptoms are similar to those experienced by almost all pregnant women. For example, the feeling of heavy or swollen legs can be a sign of phlebitis, as well as being a common side effect of pregnancy. Just like gaining weight, feeling short of breath with the slightest effort, or heart rate, which is accelerating. So many mild symptoms and completely common for most pregnant women, but which can also alert your doctor. It is then necessary to compare the different symptoms and family history to assess the risks and be able to make a diagnosis. How can we treat pulmonary embolism? As we have seen, if the clot is large, the pulmonary embolism can block the arteries and be fatal for the mother. This is why, as soon as the diagnosis is mentioned, the expectant mother is immediately treated with anticoagulants. These are heparin stings, which work faster than tablets. It is prescribed throughout pregnancy and generally up to 6 weeks after delivery. The risk remains because the vessels were shaken at birth. The mother is then followed by a pulmonologist or a cardiologist to check that everything is back to normal. And during a future pregnancy, the doctor will prescribe.
Okay, now the pros and cons. The pros we have study ask a clinical important question addressing a shortcoming of the parent student. A multicenter student encouraging external validity, screening patient consecutivity for enrollment, enroll woman in first, second, and third trimester of pregnancy. Now in the cons, we have only enrolled participation in Netherlands and France, expressing external validity. All patients were not tested for VTE, and thus some VTE may have been missed. All, all hospitals use D-dimer aside using PEU. Protocol variations were present and in greater numbers in groups in which algorithms directed clinics toward CTPA. And we have another video.
Hi, I'm Dr. Mangla. I'm the clinical director at Smile Baby IVF and KC Raju Multi-Speciality Hospital. I'm an obstetrician, gynecologist, and infertility specialist by profession. Pregnancy, as you all know, is a hypercoagulable state. That means there is increased risk of clot formation in pregnancy. So why does this occur? This occurs due to the several hormonal changes in pregnancy, due to the progesterone hormones that increases during pregnancy. So what do these hormones do? So they cause the factors such as fibrinogen and thrombin to increase in pregnancy. So these two factors promote blood clotting, and they cause certain other factors which cause blood thinning to decrease in pregnancy, such as protein S deficiency. So the interplay of these factors can lead to increased blood clot formation. Moreover, there is also a sluggish blood flow during pregnancy, because of which the blood vessel walls are more relaxed and there is a tendency for clot formation to occur. And in addition, if there are certain other risk factors like age about 35 years of age or multigravida or associated conditions such as preeclampsia, Apla syndrome, protein S deficiency, then the patient has a higher tendency to form clots during the pregnancy.
And now we have used a bit in Ecuador. Pregnant patients first perform echo Doppler as proof of lung imaging. It seems that more research are opting for a scintigraphic than CT to determine dimer from an ELISA test. And now for conclusion, we have the pregnancy adapted years figuring what a split only in patients in one a clear suspicion of pulmonary embolism was raised, and it wasn't used as a primary screening test for pulmonary embolism in pregnant women who had no specific change symptoms. And that's it. And thank you for the session.